Welcome to Black Health Matters. I'm your host, Darryl Armistead. This is a Howard University Hospital transplant support group session led by Dr. Clive Callender, who is a noted transplant surgeon and professor of surgery at Howard University College of Medicine. Let's join today's session in progress.
Have their monthly menstrual periods, and they agonize with that. They still uh, actually are more sensitive to pain than men are. I was surprised to read that because I thought because women had actually gave birth and had so many problems. I remember my wife had many problems with menstrual cramps that maybe they were more sensitive, but uh, apparently they are more sensitive than men to pain. And that's kind of a myth that has been perpetuated for quite a while. But any of your comments relative to the finding that women are actually more sensitive to pain than men? Anybody surprised or anybody have any comments relative to that too?
I think it's two different things, though. Uh, Being tolerant to pain, being able to handle pain, and being sensitive to it, I think are two different things. What do you think?
Well, and the article is only talking about sensitivity to pain, right? And they're indicating that they are more sensitive than men, and they have more chronic pain than men, and they have more of the chronic illnesses such as uh, fatigue, easy fatigability, and the fibromyalgia and irritable bowel syndrome and those kind of things. They have that more than men do, which is a fact that the data supports. Any other comments about sensitivity to pain on the part of women more so than men?
I think I'm surprised about it. I guess it's because men complain more than women. And so, women always joke about when their husbands or someone get pain. Some people, John doesn't necessarily, but some men, when they get colds or anything, they act like a big old baby.
Oh my goodness. Oh,
I mean, have you
no.
ever heard that before? Anybody besides me? That when men get sick,
I've heard that
it's
many
like the
times.
end of the world, and they cry and they
Oh,
don't
my
cry, but
goodness.
they moan and groan, and it's the squeaky wheel that gets the most attention.
Well, yeah, it is. I think that may be a myth as well, but it's certainly well traveled that men are more likely to be crying. And, when when we're doing our donor nephrectomies, the difference between the way the men behaved after the nephrectomy compared to how the women behaved was like night and day. The women seemed to tolerate it much better, kind of along the lines of what Carol is talking about. Dr. Tatum is right that the myth is that we're crybabies and that women, as John Buchanan had mentioned, tolerate pain more than men, but they're suggesting that is not accurate. But any other comments
I
about?
think it varies in my home life and with the pain level of my husband. He was one of those who could tolerate anything, and he had a lot of health challenges. Just listening to what Carol said, my husband, my son. Now, my son sometimes, and he's an adult now and married and all of that, and he had a sniffle. I mean, she was almost there to wipe his nose, and I wanted to slap him. So it varies. Some men can tolerate pain. I think women do have a certain tolerance, um, and it's difficult to compare men and women. It depends on the individual. And then some people say if a man is less tolerant, maybe it's because he was um, more sheltered as a child or protected as a child. I don't know, but in my two experiences with the two, dad was great. My son, I don't know. He's better, a lot better. He's an adult. But yeah, he seemed not to be able to tolerate pain as much. And I think now it's changed because, and he'll tell you in a minute, he's accident prone. I mean, he can walk out the house and sprain a leg or um, break a wrist, or it's always something. And I think he's learned to tolerate it because it's one of those things where the family knew, okay, where's Chris? He must have fallen. What's going on? Um, he has learned as an adult, a later recent adult, to just tolerate it, move on. He keeps the appointments and all of that, but I can never remember his dad ever uh, shying away from pain. So I think sometimes it's how you live, how you're raised. I don't know.
Well, the data certainly supports the fact that women actually are more sensitive to pain than men. So
Hmm.
the data is uh, uh, copious. So
Hmm.
there's little question that, in point of fact, women are more sensitive than men. John Tatum, you had a comment. John, your hand is up.
Can you hear me? Can you hear
No,
me? No. You cannot hear me?
now I can hear you.
Okay. I wanted to mention about headache pain because uh, in the younger days, it seemed like women always had the excuse of headache.
Uh, excuse? How about them actually having headaches? Not exclusive headaches, but actually having headaches and having menstrual cramps and those kinds of things. So, what do you say about that? Is that an excuse or is that just the reality? Any other comments? If not,
The only other comment is that I'm talking about when it comes time uh, for um, having sex. That was the golden standard excuse. I can't. I have a
well,
headache.
but that having sex is not pain though. We're talking about pain. Having sex. You saying the excuse is that they had a headache, so they didn't wouldn't have sex? Is that what you're saying, John? You
Yeah,
saved
that's the excuse.
saved
That's
by
the
the fact that
excuse.
can't hear you anymore. Okay,
Okay, I'm saying that's the excuse.
okay, all right, okay. But no comment relative to their sensitivity to pain, though, huh? Darryl?
Uh, yeah, internet says that women have more headaches than men, and this disparity is most pronounced with migraines. And the primary reason for higher prevalence of migraines in women is hormonal fluctuations. So it's not an excuse. We're just built differently. So give them a break.
Thank you, Darryl. Okay, if there are no more comments on that article, the other article was an interesting one about uh, the fact that if you don't have osteoporosis, that jumping, tennis, jumping sports are very good for building up the bones and the muscles. So that now that has nothing to do with you're frail and you have osteoporosis because we have medications for osteoporosis. But if you're not don't have osteoporosis, that doing activities 2 to 3 times a week that include you jumping around like tennis or basketball or those kinds of things, pickleball, are good for the muscles and the bone and to prevent osteoporosis and the like. So that's the other article that we talked about, that the Post talked about this Monday. Uh, uh, John Buchanan and I put together more than 20 articles that we will now discuss. Any comments about jumping around? before we go into talking about the articles that John Buchanan has prepared for us to discuss. We do this every week in terms of identifying about 20 plus articles that tell us about studies that look at health and how we can adopt healthy lifestyles, diets, and other ways to achieve longevity. Darryl?
Yeah, I love jumping. Whether it's jumping in basketball, I don't ball that much anymore, but I skip rope several times a day, and it just makes me feel good. And there's a Maasai tribe in Africa that the Maasai jump is part of their traditional dance and rite of passage that showcases a warrior's strength, courage, and agility to transition into adulthood and attract a bride. The higher a man jumps, the greater his social standing, attractiveness to women, and pride in his heritage. And those guys can jump just over and over, 4 feet vertical. It's amazing to watch. And so, I testify to jumping.
Okay, thank you very much. Any other comments? If not, let's start the articles. Now, this is an article that I think is important because I think that the primary care doctors uh, are really positioned to be able to identify the situation of whether you need palliative or end-of-life care, and the fact that they encounter the patient early on, uh, they can prepare the family and the patient for palliative and end-of-life care. And this is something that primary care physicians are positioned to do. Uh, uh, in our day today, we have more talk about end-of-life care and palliative care and hospice and those kinds of things than we ever had before. And talking about ways in which you can uh, get to the end of your life as painlessly as possible. And the fact that the primary care doctor can assist the family in deciding on which aspect of care should be given, whether it should be in hospice, whether you need more palliation, or how should this actually be terminated, is something that we are more involved with. There was a time when people would only die in the hospital. Now people are deciding to die at home among their friends and relatives, and also still going to hospice and taking the pain medication so that they don't suffer uh, pain any more than they need to. And so as we identify conditions that are not treatable, making the decision on how to deal with end of life has become more and more a specialty. Any comments? Have you had opportunities to deal with hospice or end of life care or palliative treatment for people, for your relatives who may have cancer or related terminal illnesses? Betty Blaylock?
I'm still messing with my audio.
Oh, okay. All right. Okay.
That's me. I'm getting ready to cut off.
Okay.
I have a comment.
Yes.
Yeah, dealing with my mother's end of life situation. I had never ever heard of palliative care prior to that. And I remember being in the hospital with her. She had Alzheimer's. And
Trying to cut it off.
yeah, that might be Betty. I don't know.
Yeah, it is.
Okay,
I'm working on it.
I'm getting
Give
an
me a
echo.
second.
Anyway, they had a whole. This was at Holy Cross Hospital. They had a whole team that met with me and talked about palliative care. I again, it was a surprise to me to see it. But they had a crew. They had a whole unit uh, that specialized in that, and it was very good. It was very good. Mom had hospice. Um, the whole hospice care situation is set up. It was, I think, in most cases, it's free of charge. Or it's covered by Medicaid, Medicare. Um, so it was very good for me to have those services. But but again, prior to her, winding down of her life at 90 years old, I never heard of it before. So I think as part of uh, our planning for end of life, we should consider including those benefits. I think there are definitely benefits to the family. Thanks.
Any other comments? Any other exposures to end-of-life care or palliative care?
Yes, this is Betty. Good morning, everyone. Um, when my son was in the hospital and they told me that he was terminal, um, they approached me with it, the hospice situation. They, his kidney had failed and they said there wasn't anything else they could do. And they're the ones that directed me to the hospice program and everything right there in the hospital. So it is really now, it's almost what happens. They give you the choice of which one you prefer. Most of the time, they recommend hospice rather than just staying in the hospital and dying. They recommend hospice, either at a hospice facility or at home. So
Thank you for sharing. Janice? Can't hear you. You're on mute.
What's the difference between hospice and palliative care?
Actually, hospice is where you can be treated at home or in the hospital to allow you to have a diagnosis and treatment and to have liberal use of pain medication so that you don't have to suffer much. So palliative care is just a term that is used to mean that we're not trying to cure you, we're trying to make you comfortable. And that for the most part, many of the patients who are in hospice are expected not to live longer than 6 months. And so it's actually end of life care that is done in a very dignified and sensitive way.
Meaning it is terminal,
Yes,
but it,
yes, yes. It's for those people who are expected not to live less than 6 months,
Mhm. Okay, thank you.
and for whom there is no cure.
Mhm.
Yeah.
Mm. All right, thank you.
And
Um,
and it's to decrease or eliminate pain and suffering as much as possible.
Dr. Callender, one time I read my mother was on hospice. I never did get a chance to use it fully before she passed, but they said it's not always for terminally ill people. It's just to make them comfortable. And I don't know why they put that in there. I guess to make you feel better or do they always have that? It's not always for terminally ill people.
It's most often for. There are certain conditions that when you put somebody on hospice, it is the expectation that they're not going to live more than 6 months. That's generally speaking what it is. There are exceptions to every rule, but that's the general expectation. Okay, if that's then any other comments?
Yes, I do have another comment. Um, Back to the home hospice situation. My niece was caring for her dad, and she actually was caring for a dad and a great aunt at the same time. And they eventually put the dad in hospice, and she wanted it at home, so he was at home hospice. And her great aunt was in a nursing facility, but then they decided to put her in hospice, but she stayed in hospice for a little while, and then they took her out of hospice. So, and she was up, really, she was 100 or 99 or something, but they took her out of hospice. But her, I guess, whatever they thought she had in the beginning must have changed, because they took her out of hospice and she lived another almost maybe a year before she passed, where the father lived in home hospice for about 17 months. And my niece would tell me on a regular basis that the hospice care people that would come would tell her that because of the care that she gave, that was prolonging his life. So they may have thought in the beginning that he wasn't going to last that long, but because of the care that she was giving, he lasted for 17 months.
Thank you for sharing. Any other comments? Okay, let's go to the next article then. This is an interesting comparison of a walking program for people who've had stroke and are recovering, and that those who were able to walk around seem to do better than those patients who were not walking around. And I guess it's not a surprise, but it's interesting the more active you are in all aspects of your life, the better off you are. And this is an example of it. It's not surprising to us that this is the case, but exercise is good for just about everyone, whether you have a stroke or not. And I think that once you get past 40, I think exercise is mandatory. John Buchanan.
Yes, the term subacute, not very serious stroke, is that what that means?
That means that you're recovering. Yeah, acute means that you actually have it, and you're in the very early stages of recovery. Subacute means it's more along. It's farther along than that. And they have periods that you tell 4, 8, 12, and 16 months, and uh, uh, as they got to more subacute or even chronic here, the more you walk, the better off you are. Any other comments about this? I don't think it's surprising, but it's interesting that on all aspects of our lives, that exercise is beneficial. And the more we walk, the better off we are. And the more exercise we do, the more uh, weightlifting we do, the more aerobic exercise, the better off we are. Okay, if there are no comments, let's go to the next article, please. This is an article that actually looked at our the way we take care of stroke patients, and identified that we aren't doing better. We're not doing the best we can, and that there are a lot of reasons why people who don't have insurance or do not receive uh, stroke rehab to the extent in a fair way so that everybody should get it. But that's not the case. And so this article is urging for us to have a system that is more equitable for all stroke patients, not just for those who have insurance, but all stroke patients. And they therefore say that what we're doing now is not what we should be doing, and that we should ensure that almost everybody, not almost everybody who has a stroke, has the same quality of recovery, and that. But this is not the case. And as they looked at the system, they found many situations where people who had strokes were denied care because they didn't have the right insurance, didn't have this, that, and the other. And this is lamentable. You know, one of the things that we have to face is that in this country, we don't have universal health care, and we're the only uh, developed country that doesn't have that. And as a consequence, we have disparities in the way people are treated based upon the ability or inability to pay for their court care. And so this is something that is lamentable, so that we don't have the health care as a right. And it's something that until we change that, this will be a situation that will be ever present. Any comments? The thing about it is that with the current administration, it's likely to get worse before it gets better.
Maybe I've forgotten. What is the rationale that they don't want universal health care in America?
I don't know. I don't know the rationale. But I think the reason is they think it's too expensive. But every other country is doing it, so why can't we? But the only rationale that I've heard is it's expensive. But to me, that's not a good reason because we spend more on healthcare than other countries, and they have universal healthcare. So they have healthcare as a right for all of their citizens. We don't. And we resisted it. You know, I remember when Mrs. Clinton came up with it and tried to foster it and was rebuked. And then, of course, Obama got close to it. But and this is a dramatic improvement. And now Trump is trying to do away with everything that has to do with Obamacare. Darryl?
Yeah, the short story reason why they're against universal health care is they paint it as socialism. Because in countries where they have universal health care, it's a government program rather than a business program.
Any other comments? Okay, let's go to the next article and let's hope we get to the point where we can adopt a system for which everyone has health care as a right, which we don't have today. Now, this is an article that talks about the fact that when you have pregnancy complications, the likelihood of getting a stroke thereafter is greater, particularly if you have hypertensive disorders or you have small uh, gestational age births and preterm deliveries. Uh, these down the road result in uh, the mothers having strokes, whether they're ischemic, often ischemic, but can be hemorrhagic as well. And often one of the clues that you get if you have problems during pregnancy on the part of the mother, this may be a signal that down the road they're going to have other problems. And so be careful to be sure that their blood pressure problems are taken care of so that you can prevent uh, strokes later on. But apparently, while the risk of stroke is low, it is increased in those uh, pregnant mothers who have eclampsia and other evidence of pregnancy complications. This is not in our age group, but for our children and children's children. Okay, let's go to the next article, please. Now, this is an article that talks about the atypical symptoms of a cerebral ischemia or stroke. And we talk about the fast and the twisting of the face and going blind and facial paralysis and fainting and other things that demonstrate that you've had a ischemic attack or brain ischemic attack. But they are pointing out there are other things that headache, unsteadiness, sensory symptoms, dizziness, confusion, and nausea, which may be atypical symptoms of a stroke. So if you have any of these things, you need to be evaluated to be sure that you haven't had a stroke. And they have MRIs which can evaluate the brain and identify whether you have a stroke, even if you have symptoms that are not typical. So if you have somebody who has headache and confusion or nausea that is unexplained, then it's important for them to have MRIs to be sure that they have not had atypical syndromes of a stroke or transient ischemic attack, which means that they have a temporary symptoms that go away, but are warnings that you are likely going to have a stroke sometime soon thereafter. TIA is a transient ischemic attack, which is a forewarning that you will likely have a stroke, and you need to have a MRI, a brain study to identify whether or not you are in imminent danger of having a stroke. Darryl?
Yeah, there are some symptom differences in strokes between men and women. Women are more likely to experience non traditional symptoms such as fatigue, nausea, vomiting, dizziness, confusion, neck pain, and jaw pain. And men are more likely to experience the classic stroke symptoms such as facial drooping, arm weakness, leg weakness, and speech problems. Other considerations are women are more likely to have a stroke after a recent migraine headache. Women may experience stroke symptoms more subtly, which can delay the diagnosis.
Thank you for sharing. Any other comments?
I don't know if I've said this story before, but once when I was having a choir rehearsal and a registered nurse, she was really experiencing a stroke. We knew something was different, but after rehearsal, she took herself to the hospital and she had experienced a stroke. And she was very much aware of it. We just thought something was strange, but not really recognizing what to do. But rather than tell everyone that she was thinking she was having a stroke, she just drove herself to the hospital center, Washington Hospital Center, and then they diagnosed that she had had a stroke.
And sometimes you can have a stroke and not be able to speak at all. We had one of our colleagues who all of a sudden he just stopped speaking, and he had had a stroke and was able to be treated urgently, and he subsequently recovered. So Sometimes the lack of ability to speak may be the only sign that you have. Suddenly somebody was talking that doesn't speak at all. John Buchanan?
And one of my co-workers, we were in the recording studio, and he had a stroke while we were recording. And everybody was looking at him. Man, he forgot the words, and but we didn't realize in the moment what was going on. Later on, we found out that he had a stroke, and he's had two or three since then. So, yes, they were the less serious kind, but he definitely, uh, after the recording session, he eventually went to the hospital, and that's when they found out that it was a stroke. But we couldn't figure out what was going on. He forgot all the words. And off the beat, he sang out of tune. Very
Yeah,
strange.
that's very atypical. All right. Okay. All right. Any other comments? Thank you for sharing. Okay, let's go to the next article. This is a post-stroke dementia, which is uh, now becoming more evident. Of course, this is the work done in Germany, but it still may be applicable to us. But the one thing that they identified that was different was that the HDL level was particularly low. And as you know, the HDL, the higher the HDL is, the better off you are. Uh, the lower the LDL is, the better off you are. But the HDL apparently is, if it's low, it is consistent with stroke. And so this is a relatively new finding that they're sharing, that you should look at the HDL, and if it's low, this is something to make you become suspicious of the fact that you may develop dementia after the stroke. That's the issue. Of course, as we know, dementia in some studies is the leading cause of Alzheimer's and dementia, the leading cause of death in older people. And so getting these blood tests may sometimes be helpful in terms of recognizing that a person who had a stroke may have a further complication of dementia. Uh, any comments about this? This is something that dementia following stroke is not something that we have really been recognizing too often, but it is a concern. Post-stroke dementia. Okay, let's go to the next article then. Now, this is cardiorespiratory exercise may boost mental cognition after stroke, and uh, all of the studies we're identifying all saying the same thing, that exercise in all conditions, stroke or not stroke, is good for you, and heightened risk for cognition problems is lessened with exercise. And so under all conditions, it seems as though exercise is something that you need to do. Aerobic exercise is recommended in all situations. It's something we talk about every time we have a session. But there's no over-emphasizing the importance of cardiorespiratory exercise and other exercises to maintain a healthy lifestyle in addition to nutrition. Any comments on this? I think it's something that So we never have a session which exercise isn't emphasized. And the minimum of 150 minutes per week is the bare minimum. And to the extent to which you double that, the better off you are, particularly if you combine it with resistance exercises. Okay, let's go to the next article then. No comments about it. The fact that the burden of strokes among Americans is increasing is this article is uh, identifying a dramatic rise from 1990 to 2021. And the increasing stroke is something that is involving younger patients. You know, you see particularly people of color with people in their 40s and 50s who are having strokes, whether it's ischemic or hemorrhagic strokes. And it's a concern. And I think one of the biggest, most important things we can do about this is to make sure that if we have hypertension, we take our blood pressure medicine daily and monitor the blood pressure at least once a day. And be sure that our blood pressure is 130 over 80 or lower. And I think that's the standard. And I think that those people who don't monitor their blood pressure and don't ensure that the blood pressure medication is keeping their blood pressure under control are more likely to have strokes, whether they're hemorrhagic or ischemic. And this is something that cannot be overemphasized because I think one of the problems is, yes, we know how to treat hypertension, but we're not taking the medication like we're supposed to, and we're not monitoring our blood pressure. And as a consequence, the risk of heart failure and stroke still are problematic. While this is an article that is outside of the United States, it's applicable to us because we have almost 4 times the likelihood of having kidney disease and strokes than white people. So that we need to be more sensitive to the needs of keeping our blood pressure under control. One of the things that's interesting, and it's kind of frightening, is that the new administrations are taking ethnicity and race completely out of all of the databases, which means that any way of identifying whether there are ethnic issues is going to be eliminated in the future, which means that they didn't care about us before, but they're going to care about us less because they're not going to be able to identify what issues are going on with us. And this is being done now, whether we know it or not, whether we like it or not. The new administration is eliminating ethnicity and race from all databases, old and new. And it's being done silently, so that not asking whether you like it or not, or whether you should do it or not, they're just doing it. Any comments about this article? If not, we'll move on to the next article. Darryl?
Okay, yeah, I like that we keep coming back to exercise, and this is a form of exercise we don't talk about a whole lot. But regular sexual activity is generally associated with reduced risk of heart attacks and strokes. Regular sex is a physical form of activity comparable to light or moderate exercise like walking. It lowers blood pressure, reduces stress, improves sleep. Um, you think about people that die while having sex. That's rarely a trigger that sexual intercourse causes heart attack or sudden death. While having sex, it can raise your blood pressure, and that's normal, but it's temporary. Overall, it decreases your blood pressure. Frequency, studies say there's a sweet spot. Too infrequent sex and excessive sexual activity can be detrimental to health, but the sweet spot they find is roughly between 12 and 103 times a year, which is that means it's between once a month and twice a week, and that's a beneficial part of a healthy lifestyle. It is not a significant risk factor for stroke. Uh, I don't know what's considered excessive sexual activity, and the internet article I'm reading didn't say what's excessive, but at our age, is probably that Luther Vandross song, "Never Too Much."
Well, thank you for sharing. Very important information. Thanks. Any other comments? Um, the next article is something that I was surprised to see, that hysterectomy and oophorectomy are associated with increased stroke risk according to this analysis, although it doesn't show a cause and effect relationship. It does show that they are associated. What that means, time will tell, because women have hysterectomies and oophorectomies all the time, but few are made aware of the fact that they also have it is an association of an increased risk of stroke. So this is a new finding that is not explained, but it's something that much study will go into. This is study from China. Whether it's applicable to us in the United States remains to be seen. Okay, let's go to the next article. This is an interesting article that talks about the use of more than one medication for the treatment of hypertension and cardiovascular disease. And it is suggesting that we should do more of this, although some would argue we already do a lot of it. But they're suggesting that poly pills is something that is more available when you have universal health coverage, and less available when you, in this country, where you have a variation of treatments for first the early diagnosis of hypertension, and then the treatment of hypertension. Uh, if you have insurance or you don't have insurance, there's a lot of variability, and this variability causes the likelihood of impact upon the health. And this again shows the link between those people who are well controlled and those who are not controlled, those who are on medications for hypertension and take them, and those who are not on medications and those who don't take them. And so this is the World Health Organization's view. And I think as long as we have the disparities in health, and one of the things that is frightening is that as they eliminate ethnicity and race and health, then they will no longer be, you'll no longer be able to differentiate or identify the group of patients who are where the disparity is. Because if you don't know what sex and what ethnicity the person is, then you're not going to know that there's a disparity. And so it's one way of eliminating a disparity is by ignorance, by taking away the information about it. And this is something that we going to have to work at, because they are right now in the process of doing away with gender and ethnicity in studies. Therefore, you will not even know that there are health disparities because you will not be able to identify it. So this is something that we have to be armed against because the battle has already begun and we're losing it already because most people are not even aware. I'm at a meeting in Cincinnati and the data is clear that this is what is being done now, whether we like it or not and whether we know it or not. So, Betty Blaylock?
Yes. What are poly pills, Dr. Callender?
That's just when you have more than 2 or 3 medications.
Um,
So they call it poly pills. Yeah. Yeah. And with hypertension, it's common that you have to have 2 or 3 medications for control of your blood pressure.
okay.
Okay, let's go on. And we talk about hypertension, we talk about heart failure and other diseases as well that require poly pills. But wherever there's a need for poly pills, you need to have the ability to pay for your medications and take the medications. And when you don't have universal health insurance, that's a problem. Okay, let's go to the next article, please.
Dr. Callender,
Yes.
weren't they doing some of that medical discrimination even before this administration got in? Weren't they doing some of it?
No, the data was always there. They're taking away any information about ethnicity and gender, which means you will not even be able to identify a difference in or disparity in health because you won't have any ethnic ability to identify whether what ethnic group is not having good health and what ethnic group is having good health. And so, no, this is brand new. Uh, uh, this is just being done with this administration. That was not done with the previous administration or any other administration. And it's being done silently. Nobody's asking for permission. They're just doing it. And so if nobody rises up and complains about it, uh, you will say there's no health disparity because we won't know the differences between different ethnicities because it's not to be recorded. And not only are they eliminating it from future, but they're also eliminating it from past records where possible. Okay, let's go to the next article. This is an interesting article which talks about the fact that there are 2 vitamin D tests that you can have. One is the 125, which is uh, test for people who have renal disease, and there's the 25 hydroxy, which identifies vitamin D deficiencies. And this article is suggesting that people are getting the wrong vitamin D test uh, because the only reason you need to do the 125 is for people who have renal disease. And for people who don't have renal disease, you need to do the 25 hydroxy test. Now, this is not something that you and I are going to be involved with, but your doctor needs to be aware of the fact that often uh, when they're ordering tests, sometimes they're ordering the wrong vitamin D test. As we know, vitamin D level deficiency are found in many conditions, including renal disease. And so it's important that if you got vitamin D deficiency, that you know about it and treat it. But it's not something that a patient is gonna know, but it's something that the doctor would know to order the right vitamin D test. Okay, I won't dwell on that because this is something that really physicians would know, but just sharing it. Let's go to the next article. Now, this is pregabalin is a drug that we know as gabapentin. And it is now being tied to an elevated heart failure risk. Actually, the drug is used so often that this finding is important to keep in mind for people who have uh, heart disease, because the association, whether it's cause and effect or not, remains to be seen. But anyway, it's enough for us to know about it to know if we're taking gabapentin that we should recognize it does have an association with heart failure. Now, keep in mind, an association does not necessarily mean that there's a cause and effect, but it implies that. And so, if you have heart disease and you're taking gabapentin, it's important to let your doctor be aware of that fact and recognize that with pre-existing cardiovascular disease, it may be a problem. Betty Blaylock?
I'm sitting here asking my husband, isn't that one of the medications that he takes? Well, he takes it for, what do you take it for?
Commonly used for neuropathy
Yeah,
and for pain.
yeah, that's what he takes it
Yeah,
for.
yeah.
So I guess what I'm asking is, he does not, as far as he know, have any kind of heart condition, but would this bring on a heart condition, or would it just
Yeah, you'd have to have a heart condition.
oh, you would have to already have the condition?
Right. So if you don't have a heart condition,
No problem.
then it wouldn't be, it's not likely to be a problematic.
Okay, thank you.
But the other thing with gabapentin for some people increases swelling. And if you have increased swelling, that makes you think of heart failure. So if you have swelling with gabapentin, then you should let your doctor know about it.
I just give it to you. Yeah, yeah, he does have some swelling sometime in his leg, so maybe better make sure.
John Tatum.
Yeah, gabapentin and pregabalin uh, are for different age groups. In other words, the younger people may be better suited for gabapentin, where over 65 may be more suited for pregabalin.
Well, either of them are associated with heart failure. So if you actually are taking them and you have a heart condition, this is something for your doctor to become aware of, that's all. But the association with edema is something that is not present in all people who take the drugs, but in some. And they are, and I think the point you're making is that they're two different drugs, and they're And it is amazing that for some people, the gabapentin is so effective at taking care of the neuropathy that it is worth the while to take it. But those who don't have pre-existing cardiovascular disease is not something to worry about. Next article, please. This is an article that interesting because super agers and this is what they call people who are still sharp in their 80s and 90s. And so we have a number of you on this call. And you're trying to figure out what makes you different from other people, and they don't really know. But it appears that lifestyle is an important factor. I suspect lifestyle with nutrition and exercise, meditation, etc., are part and parcel of it. But um, and addressing the mental exercises as well may be part of it. And the truth of the matter is they really don't know the answer. They just know that in a certain group of people who are 80 to 90, that they are a different group. They're still sharp and they test as well as people who have age 50 or 60. Uh, and so the science of super aging is still being investigated. Any comments about this? You super agers out there, any comment? Any comments out there? We like to think lifestyle is a factor. It may or may not be. We know that you have some who smoke and do everything wrong, and they still live to be 80 and 90 and have good brain and brain imaging may show that they have thick cortexes or not. But what makes one super agent different from another super agent? That's a good question. All we really know is that the more questions we ask, the more unanswered questions we have. Any more super agents out there have any comments?
We got a super ager in our group today.
Was that
None
Betty?
other than the Dr. Callender.
I thought you were talking about Betty Blaylock.
No, I think you got him.
Pearl, listen. Pearl, did you want to say something? You're on mute.
She probably doesn't know how to unmute herself.
Yeah.
Okay, I think I'm probably in the super ager group also.
Right.
And
Good.
I was just wondering, in fact, when I read this article, because I did read this one before the program, that they cannot come up with any particular reason. It's just sort of random as to who matches this criteria and who doesn't. They don't have any certain set of criteria that you need to do in order to become a super ager. So I think you just live your best life. And some people it works and some people it doesn't.
That's a good analysis, Pearl. Any other comments?
I'm kind of surprised that John Tatum didn't mention his dad, who definitely was a super ager.
Without question.
And the fact that he spent his last night playing cards. So, and to play bid whist and maybe even run a Boston if people know anything about bid whist. His mind had to be sharp all
At
the way to the
101,
end.
yeah. At
All the way to
101.
the end.
Yeah.
Plus, I do know for a fact you can't uh, include maybe alcohol as being a reason that would keep you from being a super agent, because I do know he and my husband enjoyed white lightning a little bit. So that that
Yeah.
didn't deter his age or his ability.
I
Yeah.
didn't mention it because I thought it was a well-known fact.
Well, it is a well-known fact. It is a well-known fact. Yeah. Yeah. He and his brother were both super agents. Yeah.
Yeah, the whole family, actually.
Well, we know about he and his brother.
Yeah.
Sure. Okay. Any other comments? Uh, it would be nice if we could identify the factors as Pearl had mentioned, but you really don't know. Yeah. Okay, so we just try to do the right things and hope for the best. You never know. Mm. Okay, let's go to the next article unless there's any other comment.
Dr. Callender, I agree with Pearl, because they try to tell you what the secret is, but when you reach that age, just like somebody will say, "What's the secret of being married so long?" What do you say? There is not an overall, I guess, answer for that. But people always ask you, "What's the secret for living long? What's the secret for being married so long?" My father-in-law said he used to hate those questions all the time. People come to, what's the secret of you living so long? And he wanted to tell them some other stuff, but he didn't. But I don't know if anybody else has ever experienced that on either.
Coming from a super ager, you would say that.
Well, obviously the article doesn't know either. So but in terms of the secret for uh, having marriage for so long requires both parties to be able to accept the imperfections of the other is one of the aspects of it, but there's so many other things that factor into it. So in many ways, some consider those, as you said, questions that may be difficult to really respond because for every these days, 50% of the marriages end within 10 years. So unlike how it used to be. Betty,
The ones I think that last for a long time are the ones that really pay attention to the vows they say, "Until death do you part." A lot of them don't think about that when they're having problems. So
well, they think about it until they have problems. And then suddenly they say, oh no,
they
no, no.
forget all about it.
Yeah.
Yeah, but those that hang in there, they remember what they said.
Yeah. But it's interesting. It's the women who often hang in longer than the men. But it's so often that you have, I'm on the medical school admission board, and about half of the people who apply for medical school have a single parent, and that single parent is the woman. The man has disappeared, so that's the biggest problem we have in our society. Men are often irresponsible as fathers. Uh, and it's one of the issues that used to be better handled, but is becoming worse all the time. Okay, any other comments? If not, we'll go on to the next article. And this is a very timely one that say that in order to get your COVID shot, you should talk with your doctor and get his recommendation, especially in older adults. As far as I'm concerned, you should get a COVID shot every 6 months. And of course, CDC is and they are very they want you to talk with your doctor, but I don't agree. I think if you're over 65, you need to get a COVID shot. Uh, under under 65 is another question, and of course, Kennedy is suggesting um, that under 65, you don't need to get the COVID shot. COVID is surging, and as such, getting more and more people coming down with COVID. And of course, not as severely as it was in 2020, 21, but COVID nonetheless. Any comments about this? Any of you having trouble getting COVID shots? What about flu shots? I think now's the time to start getting your flu shots. Toward the end of this month or first week in October, it's time to get the flu shots as well.
I'll get my flu shot next week.
Good, good.
I have to ask my doctor about the COVID shot because
And be sure about the double dose for the flu shot.
right on. I'm going to have to ask my doctor about the COVID shot that I got. I went for another reason. I didn't go in to see him because of the COVID shot. But the nurse came in and said, the next shot is available. You should get it. I think it might have been my 11th booster or,
Mhm.
so I got it. I didn't think twice about it.
Yeah, I think you should get it every 6 months. That's my feeling. Pearl Lipscomb.
Yes, my question is, why should you get the double dose instead of the single dose?
Oh, because your immune system at the age of 65 is getting lower and lower and lower. And so you need to get a double dose because you have a weakened immune system. The further away you are from 65, the more you need a double dose because of your weakened immune system as you age.
Okay,
That's
well,
for the flu
thank you.
shot. That's for the flu.
Okay, thanks for that advice because I have a doctor's appointment this afternoon, so I'll make sure I get
Yeah,
the
be
double
sure you
dose.
get the double dose. Yeah.
And
Okay. Someone else had a comment?
my appointment is next Tuesday.
Okay. Okay. Any other comments? If not,
Dr. Callender, you mentioned about Kennedy. Does anyone in the medical world take what he says, pay attention to what he says?
yeah, we pay attention. We don't agree with him, but we don't agree with him, but yeah, we pay attention.
Why?
We listen to him, but we don't agree with him. He's not informed.
Okay.
And I don't know if he wants to be informed. Okay, any other comments? If not, we'll move on to the next article. This is an association again of a low blood sugar, which is something that is undesirable for people who have diabetes, and that it is tied to increased risk of diabetic retinopathy, which means you can go blind. And so that the fewer periods of hypoglycemia or low blood sugar you have, the better off you are in terms of preventing loss of vision. And this is something that is a new finding. Hypoglycemia is not desirable by any means because you lose consciousness and you die if your blood sugar goes too low. So, but to keep your blood sugar above 50, above 70 is a good idea. And this is saying the lower you go, the more likely you are to get to go blind. That's the bottom line on what article is about. And the diabetics have to be sure that they keep up with their blood sugars and make sure they're not too high or too low. Too high is a problem and too low is a problem. John Buchanan?
Yes, Dr. Callender, is there any like middle range where
Yeah, you want to be between 90 and 100. Between 90 and 100 would be good.
well,
You don't want to be below 70.
what I was suggesting is there a point with the disease, with the retinopathy, that you could get a little bit of retinopathy as opposed to being totally blind?
Well, they haven't identified that yet, but they are just saying that if you have hypoglycemic events, you're more likely to get the retinopathy. But they have not quantified it to the extent to which, and the question you want to know what level does the hypoglycemia have to be for you to get retinopathy, and they have not identified that yet.
Well, more like when you do get retinopathy, is it like lowered vision before you totally go blind?
Well, retinopathy means that you have decrease in your vision acuity, and eventually, if it's not taken care of, you will go blind.
Okay, thanks.
So avoiding the hypoglycemic episode would be the key, which may be easier said than done. And that's why those people who have the monitors that keep the blood sugars at a reasonable level become important. Diabetics do have inserts that keep their blood sugars at a desirable level. But here again, that's related to the type of insurance you may have that covers that or not, which is again the problem we have with our lack of universal health insurance. Any other comments or questions about this important article? Next article, please. Oh yeah, this was they had planned to delay the hepatitis B vaccine, but they postponed the vote and decided to administer the hepatitis B dose. It's interesting that we have all these discussions about the measles vaccine, and we have eliminated measles, but now that people are not taking the vaccine, measles is coming back again. And what's going to happen with the board that makes a decision about this will be interesting to see. So we'll wait the recommendations. There are no comments on this article. We go to the next one. Very interesting to see what happens over time with all of these new members, and time will tell. This is an article that talks about involving the patient more in lung cancer and I think that this is something that is happening in all aspects of care. The patient is the central point of all decision making as it relates to the health. There was a time when the healthcare provider was the main key figure, but right now it's the patient, and they have to be involved in all aspects of their care. This is becoming more and more clear and more desirable, particularly with all diseases, lung cancer, just an example of it. And the more they're involved, the better they are, off they are. And this is the new call in medicine is to be sure that the patient's autonomy and ability to make a decision about their care is sustained and maintained. Any comments?
Dr. Callender. And I guess I agree with this article to a degree, but do you think that because we have gotten to the place that we do include the person in their care instead of just listening to what your doctor recommended doing it, do you feel like that has emboldened some people to not take this or not do this or not take shots and this type of thing?
No, I personally think that the preservation of the person's autonomy is critical. And I think it's desirable now. Whether it's emboldened them to make decisions against vaccines, I think it's worth it. I think it's important to preserve their ability to say yes and no. I just think that they should be wise about it and try to make the best decision. But I think their autonomy should be preserved at all costs. So yeah, and for some it may backfire, but I think for most people it'll work out in their best interest. Any other comments or questions about this article? Because that's the question of the day.
Dr. Callender, can you hear me?
Yes.
I wanted to know about the patient being the center of their healthcare decisions and what part the social worker plays in those decisions, and also a physician who may be a good friend who can tell you the inside information.
No. Which of those is your question? Because
It's two questions. See, the social worker is not a medical doctor, but your friend who has a medical degree could probably give you more help.
Well, I think the social worker is an important team member who contributes to the decision that the patient makes eventually. And so I think the social worker is an important player in making that decision. In terms of your physician friend, I think that they can play a role as well because they would advise you in terms of helping you make your decision about what to do with your care. So that as you make your decision about what to do with your care, I think the social worker and the physician friend may contribute to you making your decision. I think it's all fair because it's all up to you. But the more information you have from the social worker and every other team member, the better off you are.
Yep, and there's also some decisions are a family decision because, like we said earlier in the group session, we said that uh, they used to ask a question of a dying patient whether they wanted to die in the hospital or whether they wanted to die at home. And so that scenario is changing now. They're using palliative care and hospice care more now than they are relying on family decisions. One thing is
But it's not a
sometimes,
family decision. It is not a family decision. It's the patient's decision. It is not a
yeah,
family decision.
and
It's the
so
patient's decision.
and so one may be a financial decision too, because if they're on some kind of a machine that costs a lot of money, the family may say, "Well, you made the decision DNR because we can't afford to pay for this machine."
No,
And
it's not a family decision. So I think you should stop saying that. It's not a family decision. It's a personal patient decision, not a family decision. You make decision, and that's what is important about this article as well, is that it's the patient who makes the decision, not the family. And that's what the autonomy is all about, that the patient makes the decision. The family uh, may contribute to the patient's decision, but it's the patient that makes the decision, not the family. Okay, I think that's the last article, and I guess we'll close
Yeah.
with that discussion. Any other closing comments you want to make?
Yes, I again want to say that when my son was um, in the hospital and he had kidney failure and he really wasn't talking or anything like that, but they didn't approach him at all about the decision whether to move him. They approached me as a family member, not him.
How old was he?
He was 60 something.
Was that because he was incompetent?
No, I mean, I don't know that. I mean, he knew what was going on. He just wasn't speaking, maybe, or whatever. But
Well, if he can't speak, then he can't communicate.
I
So,
mean, but he could have written or, but when the lady came in about the hospice situation, she never approached him at all. She
well, she should
sat
have.
down and started talking to me.
Well, she should have if he was competent.
Yeah,
If he's mentally competent,
yeah,
then he should be the one to be his approach. Now, if
okay.
he's mentally incompetent, then the
Yeah,
next
I
of
can
kin can be
understand that. Yeah,
approached.
yeah.
Yeah.
But no,
Okay,
but she
well,
approached me directly.
yeah. Well, thank you for your attention and